Okay, so we can start today. So good morning, everyone. And we have today Grand Bounce, a new session. We had a very special speaker. That's one of our own is Dr. Papamitsakis. He's a professor when attending many tests on downstate. He's a vascular neurologist. He's also the director of the Fellowship of Vascular Neurology at downstate. So a little bit of a background from Dr. Papamitsakis. He graduated from the University of Crete, School of Medicine in 1991. He completed his neurology training at Mount Sinai. And then he did fellowship in stroke and cerebrovascular diseases at Oregon Health Science University and Henry Ford Hospital. He's been practicing as stroke neurologist. He participated in some initiation of the project Telestroke in South Carolina in West Lutheran Medical Center until 2018. Then he joined us. Dr. Papamitsakis is board certified neurologist, vascular neurology, and neuroimaging. And his clinical interests includes the acute stroke management, stroke prevention, and has been involved in several acute stroke treatment and stroke prevention trials. So I wanted to thank you, Dr. Papamitsakis, for accepting this invitation and give you all the spotlight for this presentation.
So thank you very much. I'm sharing my screen. I hope you can see it. Let me know if there are any issues or with the sound. So thanks, Sergio, for the nice introduction. So I'm trying to present today one more time the primary vasculitis or angiitis of the central nervous system. We did that a few years ago, and I think it's time for presentation again, especially for our younger students and residents. No disclosures pertinent to this presentation, and the aims and the summary of this is really to review the definition and pathology of the primary angiitis or vasculitis of the CNS. And by the way, there are numerous terminologies and primary CNS vasculitis, isolated angiitis of the CNS, granulomatous vasculitis, and even benign angiopathy, as we are going to discuss a little bit. Then we'll talk about the diagnostic evaluation and differential diagnosis of the patients suspected to have PACNS and their management. Now, what are the definitions? So when we talk about vasculitis, we mean inflammation of blood vessels with or without vessel wall necrosis, and the primary or isolated angiitis of the CNS is a vasculitis that's restricted to vessels within the dural reflections, and that's clinically and pathologically restricted to the central nervous system, which basically includes the brain, spinal cord, and the meninges. Initially, it was called granulomatous angiitis, but non-granulomatous pathology has been also documented. And the criteria that we consider nowadays classic, proposed by Calabrese, who is a rheumatologist at the Cleveland Clinic, and Malik back in 1988, is to have clinical findings of an acquired neurological deficits unexplained after a thorough evaluation, findings of classic and geographic or pathological features of angiitis within the central nervous system, and no evidence of systemic vasculitis or other condition to which the geographic pathological features could be due to or secondary. In a brief history, it was initially described, actually, I've seen some reports from even as early as 1922, but typically there was a paper in the 1950s, and it was described as more or less uniformly fatal disease. And up to the 80s, there were only 46 cases in the literature. But at that point, there was kind of a resurgence in the evaluation and management of the condition when the group down at NIH, including actually the famous now Dr. Fauci, reported a successful treatment with cyclophosphamide and steroids in 1983. And later on in the 1990s, analysis pointed to basically heterogeneous disorder with different subsets. And another kind of improvement in the evaluation and diagnosis of patients with these types of presentation was a definition of the RCVS, reversible cerebral vasoconstriction syndrome, in 2007. We are going to devote a few slides on that condition. So regarding the vasculitis of the nervous system in general, so we have the primary vasculitis that are restricted to the nervous system, either to the central or peripheral nervous system. And then we have the secondary vasculitis, which basically are due to a systemic disorder or infection causing inflammatory vasculopathy with evidence of systemic vasculitis involving multiple organs. Or we also have a systemic disorder causing inflammatory vasculopathy, but the vasculitis is confined to the nervous system without evidence for systemic vasculitis. That's a little bit of a very slight differentiation, but I found it interesting to put it there. Now, regarding the epidemiology, we don't have exact figures. We know that giant cell arteritis, temporal arteritis, is the most common of the vasculitis, with an annual incidence of up to 270 cases per million in adults over age 50. The systemic vasculitis, it's estimated around maybe up to 42 cases per million. Typically, the primary sinus vasculitis is a small percentage of the systemic vasculitis. And it's also obviously a small percentage of strokes that occur in adults, and especially the younger adults. What are the clinical features? We have typically chronic headaches, encephalopathy, stroke, seizures, but also myelopathy, especially if it's involves the cord, or although typically it doesn't involve only the spinal cord. There is a long prodromal period, and it takes some time to diagnose these patients, and we shouldn't find systemic vasculitis manifestations, peripheral neuropathy, fever, weight loss, or rash. And especially it's important to evaluate young patients who don't have any identifiable cardiovascular cause for stroke, hypercoagulable disease, or systemic disease. Now, regarding the clinical manifestations, virtually every neurological symptom and sign has been reported, but the most common is really headache with encephalopathy and some multifocal signs. There are some others: intermittent confusion, dementia, cranial neuropathies, and typically, as I mentioned, systemic symptoms are absent. Although sometimes low-grade fever, myalgias, etc., have been reported. Later on, there might be widespread neurological dysfunction, and you could have also a relapsing remitting course, as we see in demyelinating disease, or, as I mentioned, more of a focal CNS dysfunction, for example, if the spinal cord or the cerebellum is involved. We'll talk about the differential diagnosis, but it is pretty broad. Tumors, CNS infection, meningitis, demyelinating disease, degenerative disorders, and the more common causes of stroke can be in a differential. Now, it takes some time to diagnose. It's not an easy diagnosis, and it has been estimated that for patients diagnosed angiographically, it takes up to 4.5 months for diagnosis, and up to 6 months for the patients diagnosed through pathology. And the clinical course is not necessarily uniform. There is a benign subgroup with single episodes with mild involvement and no recurrences. There is the group with kind of improvement and remitting relapsing course, and the progressive group with fluctuations resulting in permanent disability or death. And the question arises, is it a single disease? What is the group of disorders? And we try to have, lots of diagnostic, tools in our armamentarium. It's most important being obviously, like in every case, the history, but also laboratory testing, and especially CSF studies and neuroimaging before we end up with a brain biopsy. When you see these patients, a systematic approach is, important, trying to evaluate obviously for symptoms of systemic autoimmune diseases, fever, rashes, joint pains, neuropathy, ulcers, oral genital ulcers, inflammatory eye disease, Angiitis, DVTs, miscarriages. All of this would signify a more systemic disease. And obviously it's important to evaluate for infectious or malignant conditions to avoid therapeutic blunders, treating with immunosuppressant somebody who has an underlying infection, evaluating the person's travel history, job description, hobbies. It's also essential. For example, people who do who are expedition cavers, they go to caves, they might be at risk for histoplasmosis or leptospirosis. Also evaluating the person for recreational drug history. Now, regarding the pathology, the primary Angiitis or granulomatous Angiitis, predominantly a leptomeningeal disease involving the small and medium-sized leptomeningeal and cortical arteries in particular, and less the veins. There are variations, even in the same biopsy specimen. You can have necrotizing vasculitis or lymphocytic vasculitis. And then the infiltrate is composed by lymphocytes, histiocytes, and plasma cells. Typically, larger cells are not involved. And the other point I want to make is that you can have obviously skipped lesions that you are all well familiar with in temporal giant cell arteritis. And that's one of the reasons that the biopsy, if it's negative, does not necessarily exclude primary Angiitis. Although obviously we are focused in the lesion nowadays with appropriate neuroimaging, I think this is probably less of an issue compared to the past when MRIs were not used. There are no uniform pathological findings. The hallmark is a significant inflammation in the affected vessel wall, and the surrounding brain might show infarction and hemorrhage. And as I mentioned, the distribution is segmental, and that's why the biopsies, sometimes they are non-diagnostic. And we see three patterns. Granulomatous is the most common with mononuclear inflammation and beta 4 amyloid. Lymphocytic, next common with occasional plasma cells, and necrotizing with transmural necrosis, which is associated with intracranial hemorrhage. And I have a couple of slides here from the publication by Salvarani showing in this panel here the transmural inflammation of the leptomeningeal artery with a prominent mononuclear here and granulomatous inflammation here, and thrombus formation in the middle. And on the right side, you see the epithelial histiocytes in a thickened vessel wall with eosinophilic material and amyloid. In the bottom panel here, you see this granulomatous pattern with amyloid angiopathy with granulomas in the leptomeningeal vessels. And then again, with this immunoperoxidase staining, there is again amyloid in the vessel. And the lymphocytic pattern is seen up here on the upper panel with luminal obstruction in the leptomeningeal vessels. And then finally, the necrotizing pattern of vasculitis with transmural inflammation and fibrinoid necrosis. And I have a couple of more slides, including one from I think the stroke textbook with predominant lymphocytes and a variable number of plasma cells and histiocytes, and another slide with the arteriolar CNS angiitis. Now, regarding the pathology in the past, they had described cases which were of angiitis based mainly on cerebral angiography. And in that particular subgroup, they thought that there was a better clinical outcome, and in particular in patients who were female, had mainly a headache, acute onset of symptoms, and no CSF changes. And they coined, some of the researchers then, the term benign angiopathy of the CNS. But certainly there was a debate in the past, and the debate continues about the prognosis of angiitis that's just angiographically defined. Overall, I would say that pathology is, essential to exclude eventually other diagnoses, and very important before initiating long-term immunosuppressive treatment to which the patient is committed. And eventually, as we are going to also, I think, mention a bit towards the end, really when we talk about vasculitis, primary CNS vasculitis, we have a definite diagnosis based really on pathology. If you have a good, let's say, suspicion based on MRI and CSF testing, then this one should be really called probable primary CNS angiitis. Again, you can have sometimes a very small silent foci vasculitis in other organs. And some people have argued that we shouldn't use the term isolated, but typically the majority of these lesions are in the CNS. There are some other clinical subsets when there is presentation similar to a mass lesion. Then you have focal CNS symptoms. When there is spinal cord involvement, myelopathy with abnormal imaging and CSF testing, and when there is a manifestation with hemorrhage, typically intracerebral, subarachnoid, or less common spinal. Spinal cord involvement, it's a very small minority of the patients. Obviously, differential diagnosis includes transverse myelitis or myelopathy if we follow the terms as we heard in the last grand rounds. Then there is the obviously a subset of patients who have a negative angiogram, especially if the smaller arteries are affected, but a biopsy positive angiitis. Leptomeningeal enhancement is also seen. Typically also in patients who have cerebral amyloid angiopathy, in addition to angiitis, which is probably around 25% of patients, and we are going to show you a couple of images. There can be obviously the rapid progressive course, as I mentioned, or presence of a solitary mass lesion. Now, how does this occur? What's the pathophysiology? I mean, these vasculitic syndromes in general result from deposition of immune complexes, but that has not been clearly supported for the primary angiitis. It has been associated with systemic viral illnesses in a post-herpetic zoster ophthalmicus, contralateral hemiplegia, which is explained as a retrograde spread of the virus from the gastric ganglion to intracranial vascular structures. And overall attempts to identify a particular pathogen that cause the vasculitis have been generally unsuccessful. There have been some mycoplasma-like structures supported, in the past, but the cultures were negative. And evaluation of techniques like PCR or other genomic sequences are being further evaluated nowadays, especially to exclude other etiologies as infectious etiology, which is very important for the management of those patients. Now, part I want to mention here is that cerebral amyloid angiopathy and Angiitis has been reported due to inflammatory response to the position of amyloid in the vessels. And these patients have also, as we've seen in cerebral angiopathy patients, overrepresentation of the ApoE44 genotype. Now, regarding the so-called atypical vasculitis, the diagnosis is suspected either by angiographic or pathological evidence, but doesn't exactly fit the criteria for giant arteritis or even for RCVS. And in this case, we try to exclude mimics. If you have also suspicion of Angiitis and unusual anatomical sites, spinal cord, or presenting as a solitary mass lesion, we should clearly evaluate these patients for an underlying infection or malignancy in detail. So just a few points, and I found this article by Dr. Haj Ali, who has worked with Dr. Calabrese in the Cleveland Clinic, pretty informative. Just to summarize, so the primary vasculitis is a vasculitis confined to the CNS, affecting the small and medium-sized cerebral vessels. It is referred as granulomatous angiitis if there is granulomatous vasculitis from brain biopsy, and atypical Angiitis diagnosed based on angiographic or non-granulomatous pathologic evidence of vasculitis. Now, what are the diagnostic modalities that we use? Obviously, we do the typical laboratory testing from white count, SED rate, serology to look for other etiologies, RPR, HIV, hepatitis C. And these tests are typically unremarkable in patients with primary Angiitis, and they cannot be used just to support it or exclude it. It's useful to eliminate underlying systemic illness, connective tissue disorder, or systemic vasculitis. Obviously, elevated SED rate is favoring systemic vasculitis, and you have typically normal SED rate or close to normal in primary Angiitis. Other tests, CRP, ANCA, all the other antibodies, anti-Ro, anti-La, and cardiolipins typically are negative. If you have ANA in low titers, primary Angiitis cannot be excluded. And then other studies, for viruses, infectious diseases are also performed. Again, there is no specific marker or precise laboratory testing for the disease. If SED rate and CRP are elevated, we should really look at systemic vasculitis, connective tissue disease, or infectious etiologies. And this just reiterates some of the tests that we do. So again, the laboratory testing is non-specific. If you have elevation of this acute phase reactants, systemic processes suggested, and when we do lab tests, which we should always do, we try to exclude other etiologies. Now, an important part is CSF testing. And basically, the reason is that it's abnormal in at least more than 80% of pathology documented primary Angiitis. It can be, however, non-specific with some lymphocytosis and moderate increase of protein, although in some of the papers that I checked, the mean protein value is elevated, I would say, to 177, and the mean number of cells is 77. Obviously, you need to include stains, cultures and serology to exclude infections. And the positive predictive value does not seem to be as important as the negative predictive value when you have a normal CSF testing. So that sways you kind of away from the diagnosis of primary vasculitis. You can have, as I mentioned, findings of aseptic meningitis, mild to moderate gliocytosis, and occasionally oligoclonal bands. And another point here that you're going to make when we evaluate the RCVS patients, that the CSF profile in those patients is typically normal unless there is a hemorrhage. And again, just summary of what we talked, that the findings are non-specific and stains should be performed. Now, regarding the neuroimaging, we do CT and MRI, typically MRI. CT is abnormal, but not in the majority of the cases necessarily. The MRI is more sensitive than the CT, more than 90% sensitivity in pathologically confirmed cases, but the specificity is not as great. And the common MRI findings are multiple. You can have areas of abnormal signal in the subcortical white matter and the cortex, mass lesion, leptomeningeal enhancement, and these lesions are typically bilateral and supratentorial. Enhancement can be also seen, especially leptomeningeal enhancement. And as I mentioned, the importance of doing MRI with the CSF testing is that if both are negative, they have really a strong negative predictive value, excluding CNS vasculitis in most clinical situations. Again, here, just that you might see maybe non-specific T2 lesions in the white matter, maybe up to 40 or so percent of the cases. You can see infarctions, large arterial territories in 1/3 of the patients. And again, it's important as we evaluate these patients to be clear what we consider the standard of diagnosis. And my opinion is, I think many of the workers in the field, is that it should be a pathology rather than angiographic diagnosis. And here it just has again a list of lesions that you might see on the MRI, from T2 cortical and subcortical lesions to diffusion weight imaging abnormalities, microhemorrhages, especially when there is cerebral amyloid angiopathy associated vasculitis, maybe small enhancing lesions, large or multiple enhancing lesions, and leptomeningeal enhancement. And we have here, a person with a 64-year-old with a primary CNS vasculitis and a T2 and T1 enhancing lesion there in the PCA and ACA territory. Another case of vasculitis with a flare abnormalities in the frontal, temporal, and periventricular region. And here again, a flare diffusion with the angiographic abnormality on relevant abnormality on the CTA. One more thing that I want to mention here is the so-called central vein sign that maybe you've heard more in the evaluation of demyelinating disease, which really points to the association between brain white matter venules and lesions, the so-called perivenular lesion. You see here in this upper panel in a patient with multiple sclerosis how this central venous sign appears in the axial, sagittal, and coronal sequences. And typically you use a higher field magnet, 3T or 7T, for this evaluation. And it looks like that it's very specific for demyelinating disease versus much less prominent in other inflammatory vasculopathies. Here I have an example of Sjogren's disease, or even here in the lower panel, biopsy-proven primary Angiitis or imaging Angiitis with changes of the vessel wall on imaging. And typically this central vein sign is seen maybe in 88% of patients with MS and only 14% in patients with vasculitis based on this particular review. Maybe more in, for example, in Behçet's disease was, I think, 34% described. So again, regarding the imaging, if you have, as I mentioned, no CSF or MRI findings, then the diagnosis is really, less likely. And you can have obviously non-specific high intensity T2 flare lesions in the white matter as the most common finding. Moving on to vascular imaging. When obviously we have Angiitis affecting the smaller vessels, we might not pick it up on the MRA. Typically we see changes in the moderate to larger vessels. Cerebral angiography has been used now for decades for the evaluation of those patients, and it shows this particular beading type of pattern with alternating areas of stenosis and dilatation. But again, the problem is that this is a non-specific finding. You see it also in atherosclerosis, in some of the infectious CNS infections, in vasospasm. So specificity in some of the studies has been reported around 50 to 60% with a similar sensitivity numbers. I want to mention here that beading, which is probably much more prominent in multiple vessels, is seen in the reversible cerebral vasoconstriction syndrome, and the diagnosis of vasculitis should not be based on the angio alone. So if you get your patients evaluate and there is an angiographic report, I don't think that the radiologist, in my opinion, should label the changes as vasculitis. You can mention that there is a vasculopathy, for example, but really vasculitis should be a diagnosis based on pathology. And overall, negative brain MRI has a better negative predictive value than a negative angio. Again, these are the classic findings of segmental narrowing are presented in around half or even less than half of the patients. It can be normal in 40% of the patients, especially with a smaller vessel involvement. In the past, as I mentioned, the benign angiopathy of CNS that was initially suggested by some of the researchers in the field is really a disputed entity. Probably better term is cerebral angiopathy or vasculopathy. And eventually we have used the term in the 2000s of reversible cerebral vasoconstriction. And again, this is just some images from vasculitis in an angiography. You see here in the PCAs a little bit of narrowing, as well as of some of the ACA branches. And again, some areas of stenosis, alternating with dilatation, this kind of the beading pattern. This is again imaging MRI with flare and with contrast, and angiography in this particular patient with the primary CNS vasculitis. Or you can have also this patient here who has kind of non-specific imaging, just major atrophy on the brain MRI T2 sequence, and really no significant abnormalities on the angiography. And this is a picture from actually a patient with RCVS, which shows this kind of beading and actually sausage. It's like pattern, which is kind of more prominent compared to Angiitis. And obviously the hallmark is that these lesions do improve within several weeks, but the definition is 12 weeks, as we are going to describe. Other imaging techniques that can be useful is vessel wall imaging, typically with a higher field MRI 3T, where atherosclerotic disease, intracranial athero, appears as an eccentric irregular wall thickening, versus vasculitic disease appears as more of a concentric thickening with enhancement in the post-contrast sequences. And this appears to be more sensitive to detecting intracranial stenosis. And here we have some contra enhancement of the proximal MCA. And here again, I just want to show you these cases. Here we have vessel imaging on the all these left-sided panels, MRA and CTA. And these are three different patients. The first one is a patient with CNS Angiitis with some enhancement in the ICA terminus and in the proximal ACA A1 on the coronal T1, and there is there concentric wall enhancement and thickening that it's appreciated. On the MRA, there is severe narrowing of the right ICA and also the ACA origin, and there is no calcification on the CTA that would point to intracranial atherosclerosis. In the second case, there is another person with intracranial atherosclerosis disease, where there is some mild thickening of the wall with eccentric enhancement, with a severe stenosis of the proximal left MCA and some calcification of the ICA terminus here. And the last one is a case of RCVS, where there is some thickening of the vessel without enhancement, with narrowing, as you see here in the MCA and ACA, and again, no calcifications on the CTA. Now, apart from the CSF testing and the imaging, there is an effort to have some potential biomarkers for patients with vasculitis, and it seems that the ones that have been more recently reported is interleukin 17, which is a pro-inflammatory cytokine, potent mediator of cellular immunity, and inappropriate activation has been linked to several autoimmune diseases. So in a report from, I think, 2016, there were much higher level of interleukin 17 in patients with cerebral vasculitis compared to patients with stroke. Also, the antibodies against the interleukin could be a potential treatment approach. Then amyloid beta, A4 protein, the APP, it has been found as lower levels in the patients with primary CNS Angiitis. This was reported, I think, in 2018. And then another, I think, breakthrough is the metagenomic next generation sequencing to exclude really infectious etiologies and obviously try to avoid the therapeutic blunders, treating again immunosuppressive therapy, patients who have underlying infection. So in this particular report from 2018, patients with chronic meningitis have, were, correctly identified having underlying infections, and we can avoid obviously, expensive testing and brain biopsy if we use these techniques. Endothelial cells in venous blood detected by flow cytometry can be also used. I mentioned the high-resolution MR vessel wall imaging, progenitor cells in venous blood, and high-resolution DSA, which might help to evaluate the smaller vessels, and even PET study, which is a little bit more sensitive and specific in giant cell arteritis. And again, as I mentioned, the issue with the angiography is that, a negative angiogram cannot be used to exclude the diagnosis of angiitis, and the positive is not necessarily diagnostic. We do, though, use more and more, obviously, nowadays, angiography and imaging compared to the biopsies or, obviously, the autopsies that were used in the past for the diagnosis. Now, moving now to the gold standard, which is brain and meningeal biopsy, which can identify the granulomatous and non-granulomatous vasculitis cases, exclude other causes, including lymphoproliferative diseases, intravascular lymphoma, etc. And typically, you try to sample the leptomeninges and the cortex if you don't see a focal lesion on the MRI, because the MRI is really helpful in focusing where the biopsy is going to take place. Then the preferred site is really the non-dominant hemisphere and the temporal tip. Now, there is also the potential for false negative results, typically because of the skipped lesions. So in autopsy cases, you might have had a pre-mortem biopsy that was negative, and then in the autopsy vasculitis was confirmed. I have to say here that probably this happens typically in the older series, where the patients were biopsied kind of blindly without the appropriate imaging when MRIs were not available. Nowadays, if you know where to biopsy, where you see an enhancing lesion, active lesion, probably these false negative results are less. But still, they do exist because there is this skipped pattern of these patients. Again, the typical results might be segmental inflammation of small arteries and arterioles, intimal proliferation, and occasionally giant Langerhans cells. The morbidity overall is low. I had looked at some case series that they reported, unfortunately, a case of fatal meningitis after a brain biopsy, but I think that that's really the exception. So it's something that obviously many patients would prefer not to go through, but it's if it's done by the appropriate in the appropriate hands, the results should be okay. Again, the specificity is high. It's kind of low sensitivity. Mimics can be identified in several of these patients underwent biopsy, and as I mentioned, if you have the brain MRI, which we should have on every single case nowadays, the biopsy becomes much more sensitive. And again, a similar summary of the points that we made previously. Now, I just want to show you this figure from a paper that evaluated the diagnostic test in vasculitis since even before the 1960s. And as you can see here, obviously the published cases ballooned after the 1980s, and we have more and more cases of vasculitis being published, and we have even more cases getting cerebral angiography rather than autopsy, which, as you see here, it's declining, or biopsy. And typically, you have even less kind of increase of the combination angiography plus biopsy. So we do tend to diagnose more patients nowadays with non-invasive ways, although these cases, as I mentioned previously, should be probably identified as probable and not definite vasculitis. Now, a few things on the differential diagnosis, which I think is important because we want to make sure that we don't miss other probably more treatable diseases. So the important one is the RCVS, which has various names over the years. Cole Fleming, you might have heard from a publication in the 80s, postpartum angiopathy, etc. But eventually, all of them were combined to this umbrella term of RCVS. And then we have, secondary, obviously, vasculitis due to infections, which we should really exclude in the evaluation of those patients, and CNS vasculitis associated with systemic vasculitis, and various other diseases, from antiphospholipid syndrome, moya, radiation vasculopathy, etc. Again, that's another differential diagnosis list, which includes demyelinating syndromes, malignancies, including lymphoma, etc. And some of these vasculopathies that are non-inflammatory, including MELAS, CADASIL, Susac, etc. So a few slides we are going to spend on the RCVS because it's a condition that we diagnose more and more, and I think most of you are very well familiar with it. So as I mentioned, in the past, cases have been diagnosed with angiographic findings with different presentations. A subgroup had the acute onset of headache with or without neurological deficits, but certainly with abnormal angiography, and this was called the benign angiopathy of CNS. And it was noted that these findings were reversible within a month to 3 months, suggestive of vasoconstriction. And this term RCVS has been used now since around 2007 to encompass all of these syndromes. And the typical symptom that kind of is a hallmark is thunderclap headache, that similar to what you see in subarachnoid hemorrhage, with or without neurological deficit, whereas the headache is kind of more chronic or insidious in the primary CNS vasculitis. And you have very prominent cerebral artery vasoconstriction, as I mentioned, kind of sausage-like on angiography. And the other important part is that the CSF testing is normal in these cases wherever it's done, because I have to admit that if it's a very typical presentation nowadays, we don't do necessarily CSF testing in patients with suspected RCVS. I have here just a case of a 47-year-old woman with thunderclap headache. You see bilateral stenosis here in the MCAs. I mean, she has more of a PCA, strokes on diffusion and ADC, and another lesion looks like with some hemorrhage and probably some sulcal subarachnoid hemorrhage here on the flare. And then in the follow-up MRA and CTA, actually, there is improved stenosis of the MCA narrowing. And these are just some panels here showing changes in RCVS versus in primary angiitis, where you can see a whole compendium of different lesions, including hemorrhagic lesions, edematous lesions, some kind of watershed infarctions, versus in the primary CNS vasculitis, small infarctions are really the predominant type of lesions that we see. Again, if you compare angiographic features, in the RCVS you have more of a smooth tapering, or the sausaging, as I mentioned, of the vessel, versus an eccentric narrowing in the patients with primary Angiitis. And here, you see, the narrowing in Angiitis versus, the, more prominent narrowing and dilatation in the patients with RCVS. Again, as a summary, it's a major mimic. It's a whole group of disorders with characterizing of the thunderclap headache with neurological deficit. The CSF analysis is usually normal, and you see this prominent beading in multiple vessels, with the pathophysiology being that of vasospasm. Again, the criteria that used is the severe headache, the multifocal segmental vasoconstriction, no evidence of subarachnoid, normal CSF testing, and the reversibility is obviously per definition what we use. Again, the headaches, as I mentioned, are a little bit more chronic and progressive. Obviously, the typical type of patients, it's younger patients, women, actually more than men in the RCVS compared to the vasculitis. And then another, kind of comparison between the two conditions. And I think that obviously nowadays it's, we're much more familiar with the RCVS. We think about triggers and, the diagnosis. I don't think it's as exotic as in the past. I'm just bring you this as an attempt by the group at MGH to use this so-called RCVS2 score based on the presence of triggers, especially of the thunderclap headache, intracranial carotid involvement, and also the presence of subarachnoid hemorrhage or female or not female patients. When there is a score basically greater than 5, we get into definitive RCVS diagnosis. And these are the scores that they used. As you see, that thunderclap headache is, major one, as well as the triggers. A few things, because I think we are getting to the end. We want to have maybe a couple of minutes for questions. A few things about secondary cause of CNS vasculitis, Wegener's, Behçet's disease with orogenital ulcers, uveitis that you've heard. In the neuro-Behçet, we have meningoencephalitis of the brain versus sinus thrombosis, microscope polyangiitis, Churg-Strauss. All these are conditions that we work a lot with our rheumatologists to exclude when we have a patient with a potential CNS vasculitis. Autoimmune diseases include lupus, Sjögren's, Hashimoto, and typically we try to exclude this so-called BEE, immune-mediated condition affecting the brain, eye, and ear, which include the Susac syndrome that might be able to talk briefly, Kogan, other demyelinating diseases, MS, neuromyelitis optica, and other granulomatous disease as sarcoidosis. Obviously, infectious etiologies are very important, and we try to to exclude them before we make the diagnosis of primary CNS vasculitis. Intravascular lymphoma, it's a tough diagnosis. I think most of these cases, they have been diagnosed either an autopsy or biopsy. Obviously, you can have some clinical pattern of elderly patients with weight loss, fever, encephalopathy, etc. But this is really not very specific, including the imaging findings. Just a couple of things about the amyloid beta-related angiopathy. In patients with CAA, there is a reaction to the amyloid deposits leading to intravascular perivascular inflammatory reaction. This is considered a kind of a subset of primary vasculitis. The presentation is a little bit different in the older patients, 7th versus the 6th decade for the primary Angiitis. The symptoms are behavioral changes, weakness, seizures, headaches. And in the MRI, you can have leptomeningeal enhancement and microhemorrhages. And the treatment is actually similar to vasculitis in a more severe case. And I have here just, a panel with how it appears on the flare, with some leptomeningeal enhancement on the post-contrast T1 and multiple microbleeds on the SWI. Susac, I think we might have also heard it. You have this triad of encephalopathy, hearing loss, retinal artery branch occlusion. It has kind of a remitting relapsing course that might be similar to MS. And the typical thing is a white matter change on the MRI, and especially the corpus callosum. And I have here a case where you see the lesion, in the body, and here also in the spleen of the corpus callosum. Now, what is the treatment? Basically, steroids have been the mainstay, but back in, as I mentioned, 1983, with the first publication from the NIH of cyclophosphamide along with steroids, that has been also used. Obviously, cyclophosphamide is not a medication that we use lightly. It has side effects, cystitis, malignancy, myelosuppression. And nowadays, we use maintenance with azathioprine, methotrexate, Cellcept, or even with rituximab. And obviously we need to do also prophylaxis against infections, osteoporosis, with prolonged treatment of steroids. Just moving on, this has just a list of infections for whoever is interested. A few things about the general diagnostic approach. So obviously we need to have a thorough clinical evaluation, as I mentioned, to exclude the systemic vasculitis. CSF should be performed really in all cases, along with an MRI, typically with contrast. And angiography can be supportive, obviously, if it shows the classic findings and other conditions have been excluded. But biopsy that's directed to the MRI lesions, including also leptomeninges, is very important, especially before you commit the patient on a significant, treatment. And we try to have obviously clinical evidence, laboratory, CSF, imaging, and histological evidence to have a clinical definite diagnosis. And this is what has been proposed by Birnbaum and Heilman, that we really call it definite if you have confirmation of vasculitis on the biopsy specimen. And in the absence of confirmation, you really should call it probable. Now, the treatment is empirical because we don't have randomized trials. We have observational cohort studies. There have been obviously other trials that at least I have encountered in treatment of vasculitis, giant cell arteritis, Wegener's. And typically, it's the treatment is with steroids, and then cyclophosphamide, followed by maintenance. And that appears to be the best approach, as it has been published in some of these case series, including the one from France in 2018. So it's not anymore, a uniformly fatal disease as it was considered back in the 80s. Again, I think that this treatment should be reserved for patients with histologic confirmed Angiitis, although, as I mentioned, nowadays probably we don't do as many biopsies as previously, and other medications can be also used. There was this attempt to get a kind of an international study back in 2014, but I don't think it was bear any fruits. Nowadays we have just some case series of treatments showing the results of the treatments that they do, including this case series from Cleveland Clinic that showed around 10% mortality and kind of a a mild disability as, as an outcome. So overall, the mortality is higher, but it looks like it's less, compared to the early days of the CNS. And finally, and that's, I think we are finished here, just our conclusions. I think we need to have a better definition of this disease, especially for the cases that are not based on pathology. The definition of the RCVS was obviously a breakthrough in eliminating some of the mimics. National registries would help in defining the disease and improve diagnosis and treatment. We should spare no effort to evaluate the patient for secondary vasculitides. And just as a general statement, is one of the more difficult diagnosis thing in medicine to establish somebody who has primary CNS vasculitis, and you really need a team, including a rheumatologist, neurologist, neuroradiologist, surgeon, and neuropathologist. And with that, I thank you very much. And I don't know if you have a couple of...
Yes, there's some time for like a couple of questions at Papamitsakis. So
yeah, no problem.
the microphone is open for the participants, or even in the chat if there is any question.
Okay, I think either it was very well explained or it was completely,
Yeah.
Good morning.
So anyway.
Yeah, there is a question. There's somebody. Yep.
Yeah. Hi, can you hear me?
Of course.
Yes.
Hi, good morning, Dr. Papamitsakis. Thank you
Yes.
so much for the presentation. It was really enjoyable. So, I'm Aparna Paryadit. I am one of the neurology applicants for the season. So my question to you is that, do you think there is a scope for non-invasive techniques like ultrasound to be used instead of biopsy for diagnosis?
Yeah,
Something that's
to be honest, I haven't encountered this in my, experience and the readings, obviously, because, I try to look what's the newer things here. I know that ultrasound is used in various specialties. I mean, recently I remember we had our rheumatologist colleagues diagnosing types of arthritis just by doing a bedside ultrasound. But I don't think that this is going to be specific. Even, I think the wall imaging, I think, has a much more prominent way to assess these patients, with the results that I showed you compared to, let's say, intracranial athero, because that's really the main, the main question. Do these patients, the angiographic lesions that we see, let's say, on cerebral angiography or the typical MRA, are due to atherosclerotic disease or to a vasculitic process? So if you do maybe wall imaging showing this particular, less eccentric lesions which you see in the ICAD, more concentric, significant enhancement, maybe that would be a better option. So ultrasound, I haven't encountered it.
yeah.
I'll check it, but I don't think that that would be of a major help.
Yeah, there is actually currently an ongoing research going on the same, I guess at Mayo Clinic right now. So I was wondering if you had any firsthand exposure to.
It's a major program. I mean, the big cohorts that have been published are, I mean, I mentioned here the Cleveland Clinic because Calabrese is kind of the grandfather of, vasculitis, primary vasculitis, but there is, the big French group. I mean, we are talking now about 100 patients. I mean, we are talking about thousands of patients. And there is the other group at Mayo Clinic with, the Italian, I think there is a visiting professor, Dr. Salvarani, that I used actually several of his, presentations, papers, information in this presentation. I mean, look, I mean, everything that's, less invasive is desirable, but, eventually, I don't think that you can also make a good argument that this is a definite diagnosis, as I pointed into the presentation. You should, if I don't know what are the exact findings with the ultrasound. And you know, are you talking about TCD now, the transcranial Doppler?
No, I've just heard that they've been using ultrasound for it, but there has not been like a proper evidence.
I'm curious to see what exactly, because the only way, I mean, I guess if you look at the intracranial vasculature, you're going to do TCD. Now, TCDs,
I cannot
I mean,
hear
we are
you.
very good in getting velocities, but as far as I know from my understanding, to look at the vessel wall, that's not so easy. But I'll be glad to look it up, or if you have anything, feel free. I want to be educated also in this subject.
Thank you. Thank you so much for answering my question. Have a wonderful day.
You too.
So I think this is all for today. Dr. Papamitsakis, thank you so much for these great presentations. Thank you all for the participants, and we'll see you next Friday.
Of course. Thank you very much, and have a nice weekend.